we have been performing the Galleri test for early cancer detection for over 2 years in our office, actually going on to 3 years now. And over 200 patients have used this test, and we have a fair number of positive tests that we have picked up. We have a special guest in the studio today. His name is Arthur. Arthur is a medical science liaison officer with Galleri, which is the testing company that offers us the liquid biopsy, which is a blood test that picks up 50 different, actually more than 50 different types of cancer with one single screening tool. So Arthur, welcome to the show.
Oh, thanks for having me, Dr. Ummat.
You know, cancer is such a difficult thing, and it's difficult to take the test, it's difficult to talk about it. As you and I know, the statistics are that if we pick it up early, 9 out of 10 will survive for 5 years versus 2 out of 10 if we pick it up late. What is a typical patient? What types of patients can this test be used for? And how frequently would you recommend that somebody take this test?
Our clinical trials have mainly focused on patients that are 50 and older. And based on preliminary evidence, the test can be done annually in these patients. The reason is if a patient or a cancer is not picked up on the first go-around, then we want to have additional chances of catching that cancer over time before the cancer becomes symptomatic.
Sure.
If you do have patients that are younger than 50 and they express an interest, we really encourage them to have this in-depth conversation with you or their own physician in terms of whether this is right for them.
There are variations for individuals, for families, for people.
Absolutely.
And people have their own perception about what their risk is. Like, you know, one of my first patients was 81, and he requested it because he wasn't being screened and he had risk factors. And so it has to be individual decision, but the guidelines are very helpful. So, you know, 50 to 79 are the guidelines, and I appreciate that. And then I also look at, you know, were they a smoker or not? Are they obese or not? Are they diabetic or not? And at the end of the day, it's the patient's decision. I can only help them in that process. So you give them the right information and you let them decide what they want to do. Some may be too scared and may not want to know, and others want to know so that they can be proactive in taking steps to prevent it from progressing and getting worse and getting the treatment on time. So everybody is very different and unique.
Absolutely.
But having said that, Arthur, tell us a little bit more about the test itself. So once a sample is drawn, what happens?
Because the test is prescription only, it does require a physician to order it for the patient. When it arrives at the lab, the blood sample is evaluated for this methylation abnormality or really a methylation pattern. And the methylation pattern is then compared to our database of sequences to look at whether this is consistent with patients who have previously known to have cancer and what their patterns look like versus patients who were no cancers and what their patterns look like. And really it's a comparison to decode what that pattern is representative of. And if it's consistent with patients who have previously had cancers, then that could indicate they're at increased risk. And that's when they receive what we call a cancer signal detected result.
Okay.
For patients who do receive a cancer signal detected result, one of the really interesting and significant aspects of the methylation pattern is it also can act as a sort of a fingerprint, which can point us to what we deem the cancer signal of origin, where we believe that cancer signal is coming from. And that is there to help you as the physician guide the diagnostic workup more expediently.
What is a multi-cancer early detection test, and how does it work?
Currently, cancer screening is really looking at one cancer at a time. So when patients are eligible for population screening, whether it's for breast cancer or colon cancer, it's looking just for that one cancer.
Correct, yeah.
Multi-cancer early detection is developed using blood samples that have an ability to screen for multiple cancers simultaneously. And the test works by analyzing the blood for what we call cell-free DNA fragments that are being released by the cancer into that patient's blood for collection. What Galleri has been able to do is identify what that abnormal signature looks like and establish whether a patient who's giving their blood has an abnormal pattern or a pattern that's consistent with no cancer. we really think of multi-cancer early detection or Galleri as a complement, an enhancement to supplement current standard of care screening.
Great, because that's what it seems to be a very common question. You know, all of my patients want to know if they can cancel the endoscopy or if they can cancel the colonoscopy because they did the Galleri test and came back negative.
Yeah.
But so far, I've been telling everybody that it's a different way of looking at things. It's one and the other complement each other. They do not replace the other. Currently, there is no recommendation for screening for pancreatic cancer. In fact, more than 70% of the deadly cancers have no screening recommendation. So these are complements. They do not replace each other. What is the specificity of this test? And are there a lot of false positives? You know, if I did a test for a patient and it came back positive, would that mean that they really have the cancer? What is the false positive rate? Because that can cause a lot of anxiety.
Yeah. Let me share with you a statistic around that. The test was carefully designed to have a very high specificity, 99.5%, to avoid false positives. And so the false positive would be 0.5%.
Wow.
And so that means on average, if 200 people without cancer were to get tested, only one of them would come back with a positive. In addition, when we put all of the statistics together and think about the prevalence of cancer in the population, we come up with what we call the positive predictive value. So what is the chance when you have an abnormal result that the patient's result indicates really cancer? And that's calculated to be in the neighborhood of between 43 and 44% based on our clinical studies.
Okay. What kind of clinical studies have supported Galleri development?
Oh, great question. We have really a robust research and development pathway, and to date, we've enrolled over 385,000 patients in a number of different studies.
Wow, that's amazing.
Absolutely.
So, you know, the original two studies, the Pathfinder study and the CCGA-1, had more than 20,000 patients. So now you're saying there are more than 380,000 patients enrolled in studies.
Absolutely. And looking at a variety of different outcomes, one of our big partnerships is with the National Health System in the United Kingdom, where we're doing a randomized controlled trial studying patients receiving Galleri and those receiving standard of care. Recently, we started enrollment in a study called REACH, short for Real World Evidence, to advance multi-cancer early detection health equity. And really looking at different populations to show if there's value and benefit to screening them with multi-cancer early detection.
As we prove that it is effective, it is beneficial, it does reduce mortality and morbidity and saves healthcare dollars, then we will reach the goal of early detection, which is what we do at Longevity all day long. The earlier we start, the better the outcome will be. The earlier we make the changes, the longer life will be. And it's all about improving health span in lifespan. So with that, Arthur, thank you so much for coming today. It was a pleasure to have you.
No, the pleasure is all mine.